which was an earlier model. Now people putting navigation. Now they come up with the latest navigation, which for pillions is very, very good. They started using the striker navigation, which is.
Meanwhile, any questions to be asked?
That you cannot divorce. The patient will not leave you. Whatever you do, good or bad, patient will not leave you. He'll be after your life. And will not pardon you also. So one has to be extremely careful, at least picking up a patient in this nice technique. And sometimes you get very good result and unexpected result, and your patient is doing what she was not doing earlier and enjoying it. So who is a candidate for knee replacement? Any patient who has severe persistent, and we are talking of adults, any patient who has severe persistent knee pain, secondary to degenerative knee disorder, affecting activities of daily living, with or without deformity and instability, requires regular analgesics and exhausted. This is very, very important. Has exhausted other conservative modalities, is motivated enough to undergo surgery and participate in the rehabilitation program. Why I'm saying so? Because the patient has come himself for surgery, not brought forcefully by relatives. And the patient and relatives, they understand the limitations of total knee replacement. They are not asking for sitting on the floor or other activities. And the X-rays definitely show a degenerative arthritic phenomenon. So these are the patients who are candidate for knee replacement and would be grateful. And when you pick up a patient, do not forget to examine other systems like hip, spine, neural and vascular. It looks superfluous, but it is very, very important. I keep on seeing patients sometimes who come to us with no relief of knee replacement and they have problems in the spine as well. So it's always nice to examine it. What are the absolute contraindications? Active knee sepsis, chronic pyogenic infection in and around the knee, extensor mechanism dysfunction, even if you do knee replacement, it's not going to improve, and severe peripheral vascular disease. When I say severe means patient tends to have repeated ulcerations or has a lot of problems like in the intermittent claudication, vascular claudication. So these are the patients who need that taking care of vascular disease first and then thinking of all this. Just to share with you, this patient whom I did a knee replacement, if you see carefully, if you see here, there's a popliteal artery stent which was put about 5 years back. Patient had undergone an arthroscopy, had multi-severe knee pain. So we took up this patient and we successfully were able to conduct a knee replacement, but we were aware that we are handling such a patient. And in the case where we find calcified arteries, one has to be very, very careful when putting tourniquet, avoid tourniquet and use only for cementation if possible. Relative contraindications, decarbotum deformity, secondary to muscular weakness or neurological problem, because it tends to recur following to knee replacement, and the chances of loosening are more as compared to normal situation. Presence of well-functioning knee arthrodesis when the patient is fully adjusted is a relative contraindication. If the patient is socially able to manage, because prospects of successful arthroplasty are not so good in this case. We require a constrained prosthesis, and in the event of failure, re-arthrodesis may not be as successful. So these are relative contraindications. There are articles in literature where even in neuromuscular problems, care has been done. But it all depends. The patient should be really disabled to carry out. Other relative contraindications, medical conditions that preclude safe anesthesia, inadequate or improper soft tissue coverage, post-burns, post-scab, Charcot arthropathy, again, relative contraindication. There are papers in literature where TCAR has been done, it has lasted, but not so long. History of osteomyelitis around knee joint. I burned my finger in one case with a history of osteomyelitis of femur, did TCAR, started, because even after 10 years, I started coding. Any preoperative condition that can adversely affect the patient outcome. We keep on getting patients who are diabetic, on insulin, with peritoneal neuropathy, and nephropathy. These are poor candidates for any surgery. If you have to take them with guarded prognosis. One has to be very careful or pick up these patients with caution who have been wheelchair bound for years, and one fine morning, one of the rich relatives comes and says, I will get you all right. Get the patient to you for knee replacement, unmotivated patient, they've been on wheelchair for 5 years, or 6 years, or 10 years. Some of them might have psychological disorder. I just shared with you one lady, this lady who was wheelchair bound for almost 20 years, rheumatoid. I put her up as a challenge, did the replacement. If you slim wheelchair, because later on I came to know she's on medication for depression also. She keeps on having dreams that I will walk, I will be dead. So one has to be very, very careful, talk a lot to these patients, especially those who are wheelchair bound, who have been non-functional. They might have something in the upper story as well. Patients with minimal disability, these are the ones who are not so happy because the pre-operative disability does not justify knee replacement. Just to share with you, this patient is 66, was advised knee replacement, came to me for knee replacement. I asked him how long can you stand, how far can you walk. He said, standing and walking is no problem at all. I go for a morning walk for 3 to 4 kilometers a day. I said, what is the problem? He said, I feel pain when I climb stairs. These are the patients who will not be very happy after knee replacement because the pre-operative function is so good. They just need conservative treatment, some reassurance. And it's almost 3 or 4 years now. He's been doing good. Another patient I just want to share with you, poliotic right lower limb, left lower limb was normal, non-poliotic. Was walking around for till last 1 year or so, came wheelchair bound. We have tried conservative treatment, given a local injection, ibuprofen injection, all conservative treatment has failed. Now I'm going to pick up this patient for surgery, but again, with very guarded prognosis. He said, okay, I don't want to live this kind of life in wheelchair, please go ahead. So all these patients who are on wheelchair are still very careful. Why so? Because you are answerable to yourself, you are answerable to the patient, you are supposed to give a good result, undoubtedly. What was the previous scenario? The previous scenario was, society used to think doctors are next to God. Now, there is no forget this. What is the current scenario? The current scenario is, this is the thought of the public. Doctor is service provider, punishing if it does not so well. So if you do not give good result, you might be in trouble. Thank you very much. Selectively picking up those patients, the only thing you have to give them warning, you are shuffling it will not move. Shall I go to the next talk now? So, I will just show 1 or 2 pictures which I want to show with you. I tend to replace majority of the patella because I use posterior stabilized design, PS design, and as is recommended by Professor Ranawat and others. We have a tendency to put patella supromedially, but one should not exaggerate this. That to be in the center. This is an osteophyte, and you need to see your scalar view very carefully. If you see scalar view very carefully, you see this much is osteophyte. So one should not place your patella on the false bed of osteophyte. See, here is the osteophyte. This is the patella bed, this is the osteophyte. So don't place your false patella on osteophyte. That is one message I want to give if you are planning to replace patella. Now I'll share with you the video of how do I replace patella. We deprive the superior margin, take off the synovium, come all around. You'll find a thick layer of synovium here. Just to expose the nose of patella. Now margins are very clear. You need to expose it all around. Remove as a synovium. Measure the patella, the thickness of patella. Your femoral component will tell you what size patella shall match this. Before actually cutting, I tend to have an idea of the size. This is too big. Seems to be okay. And there are color coding at how much you need to dissect, in what size. You have measured your subtract, how much you have to dissect of the total thickness. Set your jig. In this case, it was 17 to be set. Nowadays, we have a newer jig available in HP set with PFC. If you check nicely on the prompts, with an engineering, you can have an idea where you're going. Once you avoid going below the lateral facet, you're still safe. We are happy. You need to protect the margin of skin here with any instrument. I asked my assistant to keep it parallel to the floor, because in all these jigs you can move here and there 1 or 2 millimeters. I'm always very conservative in my initial cut. Always measure how much I've cut, what is left. I can always redo it. There is very less margin of error available for product. Female integrated still has.
It's not as you don't use any saline.
Saline I can use it. We are videographing and recording it as well. Refining your cut. One can see how hard the banana is. If you have removed the desired bone, fantastic, or else go ahead and burn it a little bit more. You can do it freehand also. Measure the residual thickness. It has to match our calculation. We place our jig, we tend to place it centrally, because if you are far too eccentric, there are chances that you put it in a thin bone and you can fracture it. This is far too eccentric. Using a hammer to put the jig, it has to be absolutely 90 degree. Your long prong has to be 90 degree to the long axis of quadriceps tendon. We use a small bowman to give counter. My assistant is using a small bowman here to give counter. To make love holes. remove extra osteophytes. You can do it now or you can do it even after implantation. Remove osteophytes, extra osteophytes. Make it dry. Now use a thin layer of cement on the patella surface. Putting the patella will be pressurized with the fingers and thumb. I will never put down pressure with a jig. In a thin patella you can break it also, especially in rheumatoids. So whatever pressurizing you do, you use your thumb and fingers to pressurize it. You use it when you use the jig as a holding device, as a holder, that's all. We don't pressurize with this. And to remove excess cement, use a sharp instrument, don't try to use a blunt instrument, you pull out cement from beneath the patella. And I think that's all. Regarding the technique, any questions?
Sir, if at all,
Because patella is totally non-forgiving. Absolutely non-forgiving. You never forgive it. Tibia you can recut, you can do your wedges, femur you can play around. Patella you cannot.
Thanks. That's a very good excellent technique. We are facing more and more of the patella problem, particularly after knee replacement. I think there is a place, particularly if you are PS knee surgeon, then there is certain patients that definitely needs patella resurfacing, and the trend is towards patella resurfacing rather than.
But gradually over the years I have learned that we have surpassed the stage where we proper reflection, extension, walking. It is anterior knee pain. Crapiters, getting up from chair, and if they go to anybody else, they say, oh, he has left patella, is giving the problem. That is one. Second, I use PS design. That has been recommended. So majority are it.
sir, is there any particular relation to the size of the patella? As it is said that Indian people have a smaller patella, less thicker than it is. Then should it be done in every case, or is there any particular relation to the size of the patella when it should be avoided?
No, I don't think so. I do not follow that rule at all. The size of patella will dictate whether I can replace or not replace. As far as the Indian size is concerned, I never faced this problem that I could not replace patella because of the size of the implant. Thickness, yes. Sometimes I encounter very thin patella and I was worried that if I do patella replacement, I might create more trouble. So I go to the another board, surface, selectively surface. And especially patella baha, I am very cautious. Patella baha is very difficult, technically difficult to replace. So I err on not replacing them. So I think of doing CR knees in them if I can do that and balance them well. But if I have to jump to PS design, I try, but if it is hard to be demanding, I don't hesitate to give a quarter step, devote it fully, do replacement.
Any other questions to Dr. Nehru? Because he has to leave for surgery.
And I'm asked that from there you go to Lucknow. Your flight is 6:30. I've been asked to do surgery 3 o'clock, my vehicle is ready, go to Lucknow and fly out.
So thank you, Dr. Arora.
Thank you very much, thanks a lot.
And now may I invite Dr. Mahalingam to present the much demanded video of the bikini approach yesterday for hip. He will present a video on the bikini approach, entry approach for the hip. Hip replacement. Yesterday was a hip session. It was a much demanded video because of the dearth of time we could not present it. So today, this he will take both knee presentations later on after lunch.
Show this video. I'm just going to show you a little picture first of the long series of in what series we do. Then I showed you, it may take time or it may want me if there's any restrictions on the time. That's generally the setup. It's a regular standard table. I think I showed the table. Before that, I want to tell you, this is I genuinely feel it's a reproducible technique. It is going to be the primary hip replacement approach in the future. There's no doubt about it. And there is all the industries and the colleges, institutes are making a lot of effort on teaching this technique by doing a cadaver workshop, then going to reference centers, and also the first few cases, we most of the serious we go there to assist and to get the setup. So and we document most of the procedures. So we measure the outcome just to reduce the complications. The setup is just regular standard setup. Both legs are prepared independently up to the umbilicus, and mark the both anterior leg spine, put a line above the umbilicus so that expose the umbilicus and both anterior leg spine for the first few cases. Use X-ray imaging X-ray for the first few cases, again for cup position and reading. And if you are not a supine position orthopedic surgeon, probably get a little bit of orientation for the supine cup position in the supine position. Other than that, it is very, very safe. As I mentioned to you earlier, all part of the ilium and more, the total femur can be approached through this. So it is not a restricted approach. Standard is preparation, both legs are prepared, bilateral knee arthroscopy drapes are put in, and then offside. I'll just go through these pictures just to explain the videos, because the video may be a little bit not in synchronization, so this may help you to understand this. So the exposures, as I mentioned to you, 1/3 medial to the line joining the anterior leg spine to the fibular head, and 2/3, but it can be any length. The lateral only structure that is at risk is the lateral cutaneous nerve, the thigh, and which can be easily identified and protected. These are just a series of, and once it's a very quick access to the hip. As soon as you separate these tensor fascial lata and sartorius, you're on the hip. So put a long cobra or a woman in inferior part of the neck, superior part of the neck. That is one on superior part of the neck, and the other one is inferior part of the neck. Then the third retractor goes just under the rectus, and your whole capsule is exposed. At this stage, the only blood vessel that you ligate is the lateral cutaneous, lateral femoral. So the ascending branch, it's very big vessel. You cannot escape that. Either you ligate it or then inject some local anesthetic intracapsularly just to get your acetabular bleeding less. Then do a capsulotomy. Just take a flap of tongue of anterior superior capsule for your retractor maintenance. And if you want, you can do a complete full capsulectomy without any problem. In revision, we do that all the time. And then expose, that is the capsule you are looking at. And it's very, very clear demarcation. At this stage, you will not, once one vessel is ligated, there is no other structures to treat. That's just like one of my standard cases. You can see the capsule very, very well up to the lesser trochanter. And you can inject, make the capsulectomy, I'm doing the capsulotomy now. Then put a corkscrew on the femoral head and use the corkscrew as a leverage to sublux the head and put it back. You are basically breaking the ligamentum teres. And then do your neck cut, and the neck cut will be just close to the head because you will do another cut later. You can take any size femoral femur can be removed, because I do all the hip replacement through this approach. And measure the head. Immediately I measure the head, that is my templating. And keep the head because for the leg length measurement, you use the head as your second way of assessing your leg length. Then cross the leg to figure 4 and get the inferior capsule up to the lesser trochanter. You can see it, and now you can take the paper measure the neck from the lesser trochanter up to the desired level. Okay, make a marking and cut your neck from the neck again. This is your second cut. So I'm doing that. Then you put your skin protector and put a self-retainer, or you can use a Homer. And you will. This is the exposure you get. You can see 360 view of the acetabulum, including ligament anterioris, every part of that. You can actually put an anterior Homer, and you can do a lot of osteophyte removal either before or after the cup insertion. Then after that, cup preparation, acetabular preparation is standard, and then trial and implantation, and the only sometimes you have more space inside, and the mouth you have very restricted space. So most of the instruments, cup and all, you have to go in a different plane, put the cup inside, then you introduce the cup introducer. Then that is your cup in place, and that's the status of the cup. And majority of the time, that is the bleeding you will see. It is not a very bloody operation. Once the vessel is ligated, sorry. Then the femur, and that's exactly the thing. Now I'm just going back to the sorry. That's your femoral preparation now. Femur implant insertion. And leg length inequality measurement. Now you can change that. I also use the femoral head and the brooch and the neck. Use it as a template with your. That gives you another way of assessing your leg length. So whatever you're taking out, you're putting it back in the same level. Now I just run through few videos. That's a DHS drape. So make a window on the bilateral arthroplasty drape, then just do a DHS drape. All of us sit down. So my 2 assistants and myself, we sit down and operate. So there's no hurry. So you're just a standard skin exposure. You have to keep referencing the anterior superior leg spine, because sometimes you can go more medial, and that one you want to avoid. So keep your, put your finger and index finger. Make sure that you're always lateral to the anterior superior leg spine until you see the fascia over the TFL. So take some blunt cough or acetone. Just peel the fat off the tensor fascial and you'll see the line, and make a little nick on the second one. So now it's a vertical incision on the TFL fascia, and the lateral plane is on the anterior flap, or medial flap, sorry. I don't go look for it, but Sorry, I'll do it. That's enough. Okay.